Hi everyone, we're going to talk about Chapter 38, Musculoskeletal Disorders. Just a little history. Musculoskeletal disorders are very common in children and youth, with 1 in 8 seeking medical attention annually from them. These can include things such as athletic injuries, foot injuries, knee injuries, shin splints, stress fractures, back pain, etc. There can be congenital issues that cause some of these disorders, such as anomalies in the spine, the hip and foot, growth disorders, and developmental disorders, as well as metabolic and neuromuscular disorders. These disorders can present unique problems because as the child continues to grow and develop, they can contribute to the extension of the certain conditions. I'm not going to go over the anatomy and physiology of the musculoskeletal system, but review those pages. As you're reviewing anatomy and physiology, be sure and to explore more about the different Tanner stages, as this is going to give some indication on growth spurts as the child approaches adolescence. Muscles and bones can be impacted by local and systemic problems, and we're going to discuss a few of those. So some of the systemic concerns might be infection, whether it be viral, bacterial, or tubercular. Could be hemophilia, sickle cell, an arthritic disease, or it could be a malignancy. There are also genetic problems that can impact bone and muscle health, including osteogenesis imperfecta, Down syndrome, and Marfan syndrome. With genetic issues, it's important to explore the family history, as if one child has had issues with a dislocated hip, scoliosis, etc., the risk for that condition increases for other siblings. The pediatric provider needs to also have a good understanding of the genetic disorder so they can monitor it related to orthopedic problems, consider what genetic implications they need to share with the parents, and then provide appropriate genetic information or refer for genetic counseling. Other conditions that can occur might be intrauterine compression deformations. This is when, as the baby is growing in utero, movements become restricted and body parts can assume the shape of the area that they were fixed in. The baby needs to have movement opportunities for development of the musculoskeletal system, and if there's impact where they cannot move as well, then some deformities may occur. So two major intrinsic causes for deformities could be neuromuscular disorders and maternal oliguria hydramnios, meaning not enough amniotic fluid. Other issues may be seen include injuries such as fractures and overuse injuries. These injuries are different from the adult based on the pediatric skeletal system. There's differences found in the periosseous cartilage, the physis, and there is a thicker, stronger osteogenic periosteum of the bone that's called a callus, and there's increased growth in that, and it's found in larger amounts. Physical injuries are more common in pre-adolescent children, and these are in areas where growth plates are. You can see clavicular fractures at any age, and these injuries are usually sustained by a fall on an outreached arm or hand, or by direct force. Fractures of the wrist and the forearm take up nearly half of all fractures in children. For overuse injuries, you may see tendinosis, seen in a young athlete in the rotator cuff area from the motion of swimming. There may be pain in the psoas muscle for dancers, and injuries in the ankle for dancers, gymnasts, and figure skaters. So the correct terminology for an overuse injury is epiphysitis, and that is usually seen in a skeletally immature active child or an athlete, and it's referring to irritation, inflammation, or microtrauma of the muscles, ligaments, tendons, bones, or growth plates in their affected area. When there's injuries, it's also important to consider non-accidental trauma, especially when fractures are seen. Healthcare providers should have a high index of suspicion if an injury is unexplained. Rib fractures or any unexplained fractures in a child younger than 3, if there's metaphyseal fractures, multiple fractures in various stages of healing, or complex skull fractures should all be carefully evaluated. So some of the defense mechanisms of the bone are based on, in the pediatric bone, there is a very thick periosteum, and this is one of the major reasons for increased healing speed of children's fractures, as this area, the periosteum, contributes to the largest part of new bone formation around the fracture. There's increased osteoblastic activity in that area, and so with that periosteum being thick and having increased growth, you have that on the top, and then also normal bone growth beneath it. Also, you may see some growth plate fractures. If fractures occur in the long bones, they can produce permanent deformities. The outcome will depend on the fracture location, the type, the age of the child, and the blood supply to the affected area and what the treatment is. There is a classification of physial fractures from type 1 to type 5 called the Salter-Harris classification, and we'll review that on the next slide. And as we talked about, depending on where the injury occurs depends on if there's any permanent deformities, but prognosis for growth disturbances is rare in type 1 and type 2 Salter-Harris fractures. So as we talked about, there are 5 different types. Type 1 is a fracture in the physeus not surrounding the bone. There's great pictures in your book on page 1045, or I know that there's also different ones online, and we also, I believe, had a slide of this on our sports presentation that we did. Type 2 is a metaphyseal fragment on the compression side, and that's where a section of bone has broken off. Type 3 is physeal separation, and this is going to require an anatomic reduction, and this may be required through an open approach. Type 4 involves the metaphysis, physis, and epiphysis, and in essence it is, from a visual perspective, it is a type 2 and a type 3 fracture combined. And then type 5 is rare, as it's difficult to diagnose due to signs that you might see on radiology reports, because it's more a compression or crushing injury. Both type 4 and type 5 require reduction to prevent articular incongruity and bridging of the bone across the physis. There are also shaft fractures, and it's important to know how the mechanism of injury occurred. Closed pediatric fractures are largely caused by low energy activities and play, and open fractures are generally caused by more force. When we're going to do an orthopedic system assessment, it's important to know as much as you can about the injury, what symptoms they have, if there's pain, the location, the character, the effects on its activities, if there's a deformity noted, altered function, altered gait. You need to assess if there's weakness, decreased range of motion, if their walking has changed, if they're all of a sudden toe walking or in-toeing or out-toeing, if there's limping. It's important to assess the family history. You're looking for musculoskeletal problems in either parents or other siblings, and assessing for any genetic components. This is a key time when you want to get a detailed medical history. You want to know more about the mom's pregnancy. Were there issues during pregnancy, issues after pregnancy? You want to know about the birth history. You want to know the type of presentation, whether it was a breech delivery, shoulder presentation, if there were multiple births. Did mom have issues with amniotic fluid? Was there any form of abuse from mom for alcohol or substances? You also want to know the developmental milestones for the child, where they met at appropriate ages, such as walking and sitting. It's important to assess for any illnesses or accidents or surgeries. You want to know about trauma, any arthritic type components such as juvenile arthritis, chronic diseases, meningitis, and also any diseases that might affect nutritional status, such as inflammatory bowel disease, sickle cell disease, etc. And in your review of systems, assess for any infections, any other diseases, any congenital problems. When you're doing your physical assessment, you're going to inspect and palpate. You're going to look at skin color, if there's any swelling, any atrophy, redness, ecchymosis, scars, pigmentation. You want to note the child's posture while sitting, standing, or walking. You're also going to want to palpate the skin and note any differences or inconsistencies in the temperature or perfusion of the area. You want to palpate the bone and joints to assess for tenderness, prominence, any crepitus. It's also important to evaluate range of motion, muscle size, strength, and tone of the muscles. And if there's concerns regarding sensory or motor deficits, you're going to want to assess and evaluate the child's spinal nerves and deep tendon reflexes. When assessing for range of motion, you want to check for normal range, flexion, extension, and the rotation of the joint. It's important to know what normal values you would see in joint motion at the specific age. It's important to do both passive range of motion and active range of motion, as passive will give information about joint mobility and stability. It may also give more information about tendons and muscles that may be contracted. When you're assessing their gait, it's important to know the developmental stages of walking. Most kids might walk between 8 and 16 months. But development of normal gait depends on progressive neurological maturation. You want to assess the child walking both with and without shoes, and this is going to give more insight into the functionality of the foot. You want to compare the stance and the swing phase of the arms and the legs for both legs. Movements should be smooth, rhythmic, and symmetrical. And we know limping is a disturbance in gait, but abnormal gait can also be antalgic or non-antalgic. And so an antalgic gait is characterized by shortening of the limb to prevent pain in the affected area. And a non-antalgic gait may be caused by general weakness, spasticity, muscular disorders, or a difference in the length of the leg. Some kids may be able to compensate for some of these gait issues, but these disturbances may be more apparent when the child is tired. When looking at posture, you want to assess the pelvis and the hips to make sure that they are level. You'll put your hands on the iliac crest and then perform a pelvic tilt. Legs should be symmetrical in shape and size. The patella should be straight forward. The feet should point straight ahead. And if you take an imaginary line from the center of the heel through the second toe, that visual will indicate that their toes are pointing straight ahead. There should be an arch, except that not in babies. The spine should be straight and the back should look symmetrical. And the shoulder and the scapula heights and the waist angles should be equal. Let's talk a little bit about some special exams that you would do in the hips. The first one we're going to talk about is the Galizian maneuver, and it's to signal if there is discrepancies in leg length. There are some figures in the book that I would encourage you to look at. Figure 38-3 talks about some of these physical findings for congenital hip dislocations. With this maneuver, you're wanting to flex the hips and the knees while the infant or child is on their back, and they place the soles of the feet on the table near their bottom, and then looking at the height of the knees. This is going to give you an indication if there is any differences in leg length. The next is the Barlow maneuver, and this procedure can dislocate an unstable or a dislocatable hip posteriorly. This is done in little ones, and they're placed on their back with the knees flexed. The hip is flexed and the thigh is adducted with downward pressure. And if there is hip instability, then the femoral head slips out of the acetabulum with a palpable dislocation. It's important that this maneuver be done gently in a non-crying infant to keep from damaging the head of the femur, and one hip should be examined at a time. And typically the hip will relocate after the release of the posterior force. The next is the Ortolani maneuver, and it can be done after the Barlow maneuver or separately. And this maneuver reduces a posteriorly dislocated hip. The infant is on their back with their knees flexed. The thumb is placed near the lesser trochanter, and the second finger goes on the bony prominence of the greater trochanter. The leg is flexed at the hip and is abducted while pushing up on the greater trochanter. If you feel a palpable click, then the femoral head has reduced. If you have not done some of these in practice, I would encourage you to talk with your with your clinical preceptor and see if you can get more information on this and visualize these and participate in these. Otherwise, I would also encourage you to look at the diagrams in the book and then go to some videos on YouTube on how to do the different maneuvers. The next one is the Klissick test, and it provides an observational sign of hip placement. You put the tip of your third finger of one hand over the greater trochanter and the index finger of the same hand on the anterior superior iliac spine. There's a good figure of this on page 1049 in the book, but you draw an imaginary line between the index and the third fingers, and normally this line should run through the umbilicus. If the hip is dislocated, the line tends to be more between the umbilicus and the pubis. The next exam is the Trendelenburg sign, and it identifies conditions causing weakness in the hip abductor muscles. This has to do with having the child stand on one leg and raise one leg off the ground. If the iliac crest drops on the raised leg side, then this is considered a positive test. You can do medial and lateral rotations.